Thank you so much. Thank you, Andreas. I think latest from this morning on, when Witzke Fockens talked about something we cannot see in the CT scan, we cannot see with the endoscope, but talked about actually immunology of the upper airways and endotypes, we all feel that something is coming. And you will feel that coming in terms of monoclonal antibodies, which I will cover later in a talk. But you will also feel it coming in the total management of chronic rhinosinusitis, because we are not going to treat chronic rhinosinusitis according to CT scan and endoscope. We're going to treat it according to endotypes. Now, why is that? First of all, thanks to my PhD students, Saad Al-Sharif and Karin Jonstam, who helped me with this presentation of a first series of patients where I want to show you how endotyping can influence the kind of surgery we do, and that also includes the frontal sinus. You saw this slide this morning, and it was a bit short maybe to understand what it all says, but in general, look at asthma. If you talk to your pulmonologist, to your pneumologist, they say there's a type 2 and there's a non-type 2. This is exactly the same here. If you look at the whole of chronic rhinosinusitis, you have these patients, non-type 2, no IL-5, no IgE increase. They have inflammation, and we see that in our patients, but this inflammation is different from what we are talking of. It's very simple, actually. These patients, non-type 2, are the majority of patients without nasal polyps. This is your daily bread and butter. The other side is the type 2, and these patients tend to have polyps. Not everybody has, but most of these patients have nasal polyp disease. And it's very, as we hear our international, it's very important where do you live. This is not the same everywhere in the world. In Europe, in Benelux, let's say, center of Europe, we can say that 85% of our nasal polyps are type 2, but not 100%, even not here. And in China and some other countries, that might be completely different. Why is that important? Because it tells you something about comorbidity. How likely are you to have asthma comorbidity? 5%, 0, or 70%? And it also tells you something about how likely are you to develop recurrence. None, or 80% over the next 10 years at least. So there are big differences within this group of CRS which we have to better understand and adjust our treatment. So what we propose is that we are going from these endotypes, non-type 2, moderate, severe type 2, into treatment proposals. And this is antibiotics. Macrolides are clearly for non-type 2, doxycycline clearly for type 2 disease. Topical steroids come in here. They do very little here. And we have different surgeries, and that's what I want to focus on now. The mucosa-sparing surgery, which we learned so beautifully from Heinz Stamberger and others. And here you have more removal of mucosa in those patients with polyps. And then you have this severe type, and I will show you that I'm talking really about severe patients, where topical steroids mostly do not much. Even if you have opened the sinuses and the medication runs in, doesn't do much, you may need oral steroids, and we all know the side effects, and there is no harm doses. And biologics may come in here, and we will hear much more about it during that Congress and the next Congress. And for that kind of surgical approach here, I have termed the word reboot. Why is that? You can reboot with and without draft 3, and I will talk about these different approaches. So that's what we like to do very meticulous, really fine surgical work. That's perfect for all these cases with a non-type 2 disease. But what happens in type 2 disease? There are a lot of things that go wrong. One, we have this massive inflammation, and this is just depicting that. I know you all have not so much ideas about immunology. You don't know what plasma cells and T cells and everything exactly do, but you have to learn some of that. This is type 2, including IL-5, 4, 13, IgE. And this drives severe disease in nasal polyposis. And once more, not every patient has that, so we have to differentiate. And it's mostly triggered by germs on the epithelial layer. And for some of these germs, like Staphylococcus, we know even that this Staphylococcus is not just colonizing. We find it in 80% in our patients colonizing the polyps, but it's even intramucosally, intracellularly. And from there, it drives inflammation. I go very shortly over that. There is a lecture Wednesday morning, 40 minutes. I have more time to go into details. But very clearly, if there is Staph aureus there is much more interleukin-5 production, spontaneous interleukin-5 production. And if you kill the staph by either antibiotics or a specific viral phage, then you see this IL-5 production goes down. You see much less products of Staphylococcus in the polyp, and this is a list of different proteins. Again, I will not go into detail, but the principle is that we do not just have a problem with inflammation, with the lack of defense, no interferon gamma against viruses, no good defense about bacteria, but really we have the bacteria in the nasal polyp. So one time, I didn't agree with Witzke-Fockens this morning when she said, maybe surgery will be out. And my question was, is there a way of surgery for that kind of disease? And then we developed this sort of reboot approach. And the idea is that you get rid of all the inflammation, not just to reduce the load. No, you have to get rid of the inflammation in all the sinuses, down to the perios, down to the bone. This is very difficult work in the alveolar recess. This is difficult work in some large European people have large frontal sinuses. This means in many patients that we do a full draft 3 and totally denude the bone. I know that a lot of you have problems with that. We don't have any problems, and I will show you why. Because we leave the turbinates. We leave the turbinates. From here, the epithelium grows back over this region within 6 to 8 weeks. It doesn't take more, and it makes a wonderful difference. So what I show you here is a study, retrospective study. We're currently doing a prospective study where we looked at different patients operated in one hospital, in our own hospital. And nobody was operated wrongly, but they were operated differently. And we made sure that everything there is the same. All of these patients had about the same age. They had a lot of previous surgeries, and you see here in that case, 9 of the 12 patients with a full reboot, meaning also draft 3, had 30 surgeries before. So that's 3 surgeries before we did that kind of surgery in these patients. And others also had a lot of surgeries out of 20 here, 17 surgeries in 10 patients. And a lot of them had asthma, aspirin sensitivity in a few, and allergy in quite a few. So they were evenly distributed, even if you could say, well, these had even been operated before more, these who underwent full reboot. That may be a bad sort of platform to come from. But we made sure that all of these patients had the same type 2 inflammation. And there was no difference between any of these parameters. And here you see some of these parameters, because I always get the question, what can we measure in the blood? We can measure IgE, for example. We can measure eosinophils. We can measure periostin and other parameters. That helps us, and that will be more and more in the future, just from the serum to tell, is that a type 2 patient or isn't it? Of course, if you have increased eosinophils above 250, 300, the higher the better, so to speak, to be sure that this is type 2. If your IgE is increased, you can easily say that that is very likely a type 2 inflammation. If that patient has comorbid late onset asthma, it's a type 2 in Europe in 99.9%. So all these patients had the same basic level of inflammation, and all these patients we had in that study had the same post-op treatment, which is a full-blown treatment. They get topical glucocorticosteroid drops, they get doxycycline, they get Bactroban for the nasal cream to stop the staphylococcus. They had an oral course of steroids if they had asthma. Everything was exactly the same. The only difference we wanted to observe is the different surgical techniques. And here you see it's a small study. We have to work on that, and we do a prospective study at the moment. And you see the recurrence in the so-called non-reboot patients was 45% in just 2 years later. What does recurrent mean? It means there is a clear polyp growth. It doesn't mean resurgery or something necessary. Still, you can handle that, of course, but it just means that there is polyp regrowth. If you go to partial reboot, you can reduce that to 16%, and if you go to the full reboot, all the sinuses, including the frontal sinus, are denuded and grow back newly. Then you have a recurrence which is less than 10%. And this is how it looks during surgery. You see the skull base, the orbital lamina. Everything is white at the end. No mucosa anymore. The alveolar recess in the maxillary sinus, the frontal sinus is open. If you want to see more, Dr. Al-Sharif will talk about that this afternoon. What also appeared that not only the percentage of recurrence was different, but also the time at the earliest recurrence was clearly different between these three groups. How does it look pre and post-operatively? Here, post-operatively, this is the look to the skull base. Here you have the maxillary sinus, you have the sphenoid sinus. It looks just perfect. It's a good mucosa that has been regrown. This is the access to the frontal sinuses. And this is a patient, for example, after 2 years, with no single sign of inflammation, no sign of polyp regrowth, a perfect smell. And this is 9 out of 10 of these patients in the study. So I think what we have to learn, and this is a chance, this is a challenge, but it's also a chance, is that we do not have to treat every sort of CRS the same way. We have to differentiate. And it's much about the endotype. We have to understand endotypes and then approach these diseases totally differently, because we don't want to overtreat or undertreat. Especially the type 2 inflammation is associated with disease severity, recurrence of disease, and here we do have to do more, and that's why we introduced this reboot technique. I think we have to learn more about these results, long-term results, but I have patients that have been rebooted 8 or 10 years ago and still are doing extremely fine. With that, thank you for your attention, and if you want to know more, there is a course in Ghent and a series. Thank you so much.